Good day. I am Dr. Raymund from Victoriano Luna Medical Center, and I'm presenting my paper titled Lateral External Fixation and Kirschner Wiring for Pediatric Humeral Supracondylar Fractures. Supracondylar fractures are the most common fracture pattern around the elbow in the pediatric population. Currently, pinning with K-wires after open or closed reduction is generally accepted as the primary treatment modality. However, one of the main problems with K-wire fixation is persistent instability. Rotational control may not be achieved, causing displacement in cubitus varus. Additionally, the use of splint or cast after stabilization delays early mobilization and compromises functional elbow recovery. A new technique using lateral external fixation with anti-rotation K-wiring has been described to overcome the problems arising from K-wire pinning. Its advantages are reduction through an indirect approach. It provides rigid stability while allowing elbow motion, and involves a purely radial approach, wherein the damage to the ulnar nerve is avoided. The study design is a case series, which follows the functional outcomes of supracondylar humeral fractures treated with lateral external fixator and K-wiring using the Flynn's criteria to compare the preoperative and postoperative range of motion and carrying angle. For the surgical technique, all procedures were performed under general anesthesia. The patient was placed supine with affected upper limb at edge of bed and affected elbow rested on receiving end of image intensifier. The external fixator and K-wire selection were based on the patient's age. Trial reduction was done prior to the insertion of shunt spins. The first shunt spin was inserted 2 centimeters proximal to the fracture line and perpendicular to the longitudinal axis of the proximal humeral fragment. The second shunt spin was inserted in the distal fragment, placed perpendicular to the longitudinal axis of the distal fragment. The 2 shunt spins were used as joysticks to manipulate the fracture fragments. Final reduction was checked using image intensifier. Tube-to-tube clamps were tightened once desired reduction was accomplished. Insertion of anti-rotation K-wire was done using retrograde from the lateral aspect of the distal fragment into the proximal medial cortex of the proximal fragment, crossing the fracture just proximal to the olecranon fossa. Process for reduction, testing of elbow range of motion and stability of fracture fixation under maximum extension and flexion with the help of image intensification. Postoperatively, the patients were placed on arm sling for protection and comfort. Patients allowed for free range of motion without any weight-bearing activities. Intra care was done regularly. Postoperative radiographs were done at 4 weeks, and if noted with callus formation bridging at least 3 out of 4 cortices, the external fixator was removed. Recording of postoperative range of motion carrying angle were done in 3 trials, the averages of which were taken and recorded. The patients were followed up at 1, 3, and 6 weeks, and 3 and 6 months. The patients were followed up for a duration of 6 months. During final assessment, all patients had achieved fracture union. The treatment outcomes were evaluated using the Flynn's criteria, which measured the carrying angle and range of motion of the affected elbow. A good range of motion was defined as a maximum flexion extension deficit of 10 degrees. An excellent outcome for cosmetic factor was defined as 0 to 5 degrees loss of carrying angle, while a good outcome was referred as a loss of 6 to 10 degrees. All patients achieved satisfactory outcomes in both functional and cosmetic factors. In this series, the standard technique included preliminary closed manipulation to adept reduction, followed by stabilization with application of lateral external fixator and K-wire. Adequate alignment was achieved by manipulating the fragments using shunt spins, then securing to an external fixator. Additional rotational stability provided by the K-wire prevented secondary displacement. This technique offers the advantage of avoiding open reduction in patients even with severely displaced supracondylar fractures. The stability provided by the fixator can prevent the distal fragment from tilting into varus. Additionally, the technique utilizes smaller incisions compared with open reduction. Furthermore, this technique allows early mobilization of the elbow compared with K-wiring alone, which usually requires a splint or backslab postoperatively. In conclusion, the technique of lateral external fixation and K-wiring provides a promising alternative For the treatment of supracondylar fractures, per usual, closed manipulative methods and percutaneous spinning alone may not be effective, while providing satisfactory cosmetic and functional outcomes. Thank you and good day.